Hi, I'm Josh McDonald.
And I'm Randa Materi, and we are Hand Therapy Academy. So
We're going to
today
talk.
we go ahead, Josh.
Okay, so today we're going to talk a little bit about an ulnar nerve compression problem. One of the names for it is handlebar palsy. Comes from when guys riding or people riding like 10-speed bikes, road bikes, bicycles. The handlebars that curve down, if you lean on those too much, it can cause some compression of the ulnar nerve on the hypothenar eminence around about Guyon's canal. So let's talk about some of the implications with all that.
Yeah, and I just want to add in it really I've seen this from many different types of handlebars. So it could be, I mean, it's more prominent, I think, in the curved ones as well. But I think, it wouldn't be unnecessarily strange if you had it from a different type of handlebar as well. So
Yeah, and it's certainly like tennis elbows, not only for tennis players. We see this with people who are resting their hand on their desk all the time while they're mousing, all kinds of different things. It's just the location there got its name from that. But so there's a couple of different zones of it. When we think of like a cubital tunnel or carpal tunnel compression, it's this whole global thing because the compression there. But this one actually has some zones depending on where the compression is. So we've got three different zones. Guyon's canal runs between the pisiform and the hook of the hamate. And so if it is proximal to the hook of the hamate, it's zone one, and we have both motor and sensory problems. On that distal aspect, if it's on the medial or radial side, it's zone two, and it's going to be mostly, if not only, motor symptoms. And if it's lateral or on the ulnar side of that hook of the hamate, then we're looking at almost exclusively sensory symptoms. And a lot of times these can be like, it's not exactly, it's kind of overlaps a couple. If it's mostly motor, then maybe it's more towards zone one. So it kind of can have some blending of those zones.
yeah, it can definitely vary. And how do you distinguish this, say, from a compression at the elbow, say cubital tunnel? How are
So
you
I'll do
differentiating the two?
Yeah, I'll do a version of different like provocative testings. I'll do Tinels along the pathway of the nerve, starting at cubital tunnel and working distal. I like to work distal because if I flare that up proximal and then work up, it can be hard to differentiate. Like, is that a new tingling or tingling that's left over from 5 taps ago? So I'll start proximal and work distal, see if I can elicit some positive sign with Tinels. I'll do sensory testing down the lateral forearm, down in the hand, and then a compression where I'm actually like pressing on almost like Durkin's of the median nerve. I'll just push on Guyon's canal over top of that. And then I'll also do like an elbow flexion test for tension to the ulnar nerve through cubital tunnel, kind of differentiate that.
Yeah, that's very helpful. And I think we always know if it's just motor, then you can really be like, oh yeah, I'm pretty sure it's that Guyon's canal. But when they have the motor and sensory component, then it's like, well, how do we know it's not cubital tunnel? And that's far more common.
Yeah. And sometimes we catch patients early enough that the motor problem hasn't really developed much yet, that the early symptoms are just the tingling. And so it's like, well, it really bothers me, but they haven't, like the motor weakness hasn't set in yet. They maybe have lost some coordination, but we don't expect a lot of coordination on that side of the hand kind of to begin with. So it's not until we start testing more complicated things that maybe you would find that motor component if it is very early on.
Yeah, definitely. Okay, so they have the diagnosis of a compression at Guyon's canal. What are we going to do and offer for treatment with these patients?
My first go-to when I've got a nerve compression is to decompress and change their, like, whether it's their daily lifestyles, their mechanics on things. Sometimes it's splinting. I want to get tension off that nerve because nothing can heal until we decompress and protect that nerve. So I'll usually start with making like an ulnar-based wrist support to protect that nerve pathway. So we're not leaning on it, you're not banging into it, and then we can keep it from compressing if we're sleeping on it at night in kind of that flexion position.
Yeah, one thing I really like to do for these patients is recommend a proper bike fitting because I think a lot of times, people don't get a bike assessment done. And if they're leaning too far forward or those things, I think that can help them make sure they have the proper fitting bike. I mean, unless it's caused from something else, of course, but most commonly I've seen it in bicyclists.
Yeah. and and it's maybe even modifying the equipment they're using, having them wear like riding gloves, padded gloves there, padding the handlebars, getting different grips on there. Some of those things, just to like a lot of our modifications or treatments, it's as much adaptive equipment and compensatory strategies, but that equipment can really help.
Yeah, definitely. Or sometimes it's as simple as like lowering their seat on their bicycle. You're like, oh, that was so easy, you know?
Yeah, a positional thing for sure. Then they're not putting as much weight in their hands and can make a
Yeah.
big difference.
Yeah.
Yeah,
Sometimes it's the little things make a huge difference with these types of injuries.
yeah. Any other big treatment techniques you like to use for this?
Similar to you, like I try to think, do activity modification, ergonomics, but then also I'll go into doing nerve glides, things that make the nerve happy. Of course, if it's making their symptoms worse, we might do the nerve glide within a shorter range. Anti-inflammatories, contrast baths, anything to get the swelling and inflammation down in that region. I'll recommend those things as well. And usually, I feel like conservative treatment works pretty well for these patients. I rarely see them needing surgery in my experience. How about you?
Yeah, you can do so much with conservative. The only time that I think it really warrants a referral to surgery is if it is a very long standing problem that they've let go for a really long time. And the conservative, after trying it for, maybe six weeks or so, just to see if it's going to start to move the needle a little bit, if that's just having no impact and you start to get some atrophy, then we might say, well, maybe we need to go for more EMG testing and possible surgical. But that's like way far down the road.
Yeah, I would say that these respond better to conservative treatment than carpal tunnel does. Um, and I think it's just by doing some simple interventions, it usually works pretty well. Another thing is if your monofilament or your 2 point testing scores are really outside of the normal range, I might refer them to a surgeon sooner than later as well.
Yeah, yeah. And so that's one of the reasons why it's so important to have lots of good objective measures on the front end: provocative testing, sensory testing, manual muscle testing, all those things, so that you can both identify where they're at the beginning, how big of a deficit is this, and then give objective measures to progress them along so you can justify to them, to a doctor, to an insurance company, the effectiveness of what you're doing. You got to have that evidence to support.
If they're getting better, fine. If not, I would definitely refer them out for further testing. And then what they do surgically, I know sometimes they'll do a cortisone injection or sometimes they'll just release the canal as well, I think, depending on the severity of the injury. And also, I want to bring up another thing is if they have a fracture in there, like sometimes you can have an undiagnosed, like hamate fracture that they may not be aware of. So I would look for like point tenderness um, in that region as well.
Yeah, yeah. The nerve compression should not result in specific point tenderness with pressing on it. That's a positive sign for fracture indicators. So yeah, that's definitely a
Signs
warning
of
sign.
fractures, yeah. There you could also have, like, a tendinopathy in that region that could have some tenderness, but so I would check, differential diagnoses and testing. I would test resisted, like, ulnar deviation and ulnar facet flexion. I would test those 2 just to see if that recreates any of their symptoms because they could have a little tendinopathy as well.
Yeah, yeah,
That could be making
possibilities.
the ulnar nerve symptoms worse, so
Yeah. You mentioned something earlier. I'm curious on your answer to something. If you have a patient with, let's just call it a distal peripheral nerve compression, cubital tunnel, carpal tunnel, this, how long do you go of treating them before you say, yeah, we're just not making a big enough difference to warrant continued conservative? You need to go see someone else. How long do you give that?
So, like most things, it depends on the severity of it. So, I would just say with a mild case, if they've had a mild case that's been going on for 4 to 5 months, I would probably say, hey, it's been going on 4 to 5 months. You got to give me at least 2 months to try to see if we're moving this in the right direction. But if it's more severe, we might be doing something for like 3 4 weeks and see if it's budging at all and then send them out because I don't want them to have prolonged de-innervation to those muscles that could lead to long-term damage. And then if it's an acute case, I would say we should see it moving quickly in that direction within, maybe 3 to 4 weeks. So
Yeah, yeah.
it just depends on how long they've had it going on and the severity of it. How about you?
That's pretty much where we're at too. We get a lot of referrals right now from two different neurologists' offices, and a lot of times it's a diagnosis of carpal tunnel, and it ends up being this big ambiguous on interview and assessment. They're like, "Oh, I've got peripheral neuropathy, and I've had neck pain for a long time, and I've got numbness in both feet and numbness in both hands, the whole hand." So it just kind of becomes this whole thing, and then we've got to decide like, what is our ability to help this patient, and how long do we go before they say, if they say, yeah, this just isn't working. Well, 2 weeks in, yeah, you got to give it time. Where's your threshold for at some point we got to see some tick up in improvement? I may not be able to make it all go away, but I can give them some relief of symptoms. So just a good question to consider.
Yeah. Well, and then that's the other thing too, because we get a lot from a neurology near us too, a neurology office near us. If they have gone to the neurologist and the neurologist gives them a prescription of gabapentin or something like that, and they start taking that at the same time they start therapy, there's then sometimes you're like, well, maybe it's my therapy or maybe it's the gabapentin. So I always ask the patients too, when did they start that? Because I think it can impact, we might get some false positives that therapy is helping them based on that medication response, or vice versa. It
Yeah.
might be the therapy helping them and not the medication.
Right, right. I like to try to change one variable at a time, but when patients just want to feel better, they may say, "Give me everything at once and we'll do whatever works."
Yeah, and then maybe they have to wean off the gabapentin later. And I always
Yeah.
educate them on that too. I know the neurologist does well, but gabapentin, they're not medications you can just cut off. You usually have to wean them off too. So
Yeah. All right, lots of interesting stuff. If you have any questions on this, you can certainly check out a blog post we put up not long ago about handlebar palsy, and it talks about some of the zones with a really good image of it. But definitely reach out to us on our email, handtherapyacademy.com, info@handtherapyacademy.com, or on our social media pages.